Good morning, everybody. It's a great honor to be here, and thank you for inviting me in this such great conference. And we have just started our Rituximab study in Japan, following the Norwegian studies and Germany study. And okay, how this is.
It's green.
Green, sorry. So, a Japanese pharmaceutical company, Zenyaku Kogyo, supported this study. And just let me introduce my background. I'm a neuroimmunologist, and similar to Dr. Strobel, I see a lot of MS and NMO patient. And from this experience, we would like to conduct a Rituximab study in Japan. This is our first such immunosuppressive related treatment for MHCS patient in Japan. So in this sense, it's very precious. So you don't have to listen to this all of these, but red color studies is by us. So we show that there is a link between autoantibodies and brain abnormalities. And also we show that there is a skewed B-cell receptor repertoire. And your Norwegian Rituximab studies is very help us to start. They show there are responders. That's very important. So we learn much about your study. And the title of the study is an exploratory placebo-controlled double-blind phase study to evaluate the efficacy and safety of Rituximab in ME/CFS. Exploratory is an important point for us. So that this is a physician-initiated single-center study, and the number of patients is 30, and these patients are randomized into Rituximab first group and placebo first group. And the doses of the Rituximab is 375 milligrams per square weekly for 4 times. This is a standard regimen for various autoimmune diseases. So after 24 weeks, these 2 groups switched each other, and we will look at the biomarkers and the clinical efficacy. So for the selection of patient, this is a first trial, so we try to select a typical patient, but not restrictive to specific population. And also well-characterized, which means we recruited from our own clinic. And the selection criteria, so very simple, just adults with meeting Canadian consensus criteria. And performance status is like Bell score, Japanese version of ADL score. And the moderate to severe patient is included. And exclusion criteria is also not so complicated, just excluded concomitant autoimmune diseases or immunosuppressive drugs are taken. Some patients who started a new alternative medicine or a severe depressed patient. And prohibited concomitant medicines also includes immunotherapy or new alternative medicine, etc. And for the endpoints, we have a primary and secondary, and the secondary endpoint include clinical evaluations as well as biomarker study. So the primary endpoint is a proportion of patients with an improvement of performance status more than one at 24 weeks. So very simple, just ADL assessment is the primary endpoint. But as we prepare adjustment factors, which is PS score, moderate or severe, or prior infectious onset episode, positive and negative, and anti-beta adrenergic receptor antibody, positive and negative. Secondary endpoints includes, so in addition to the fatigue score, which is a primary endpoint in Norwegian Rituximab study, we set up a system to evaluate daily percent spine position, sitting position, or applied activity, etc. by smartphone input. And also, we collected data on post-exercise malaise record or other QOL score, SF36, Compass 31, etc., and hand grips as well. And for the biomarkers, so this is an exploratory study. So we evaluate this. This is very important. Include gut microbiome, brain imaging, include MRI and SPECT, which shows a brain circulation, and immune biomarkers, as well as metabolome in the blood. And immune biomarkers include anti-beta 1, beta 2, M3, M4 autoantibody titers, comprehensive immune cell subset analysis by flow cytometry, and specific B cell group, which is defined by the immunoglobulin heavy chain V330, which is assessed by qPCR. Because in our B cell repertoire analysis, we assume that this specific B cell population is interesting because the frequency of this population was upregulated in infectious onset patient, okay, and beta adrenergic receptor positive patient, etc. Others include just standard practice in disciplinary trial, including safety profile, etc. So that's all. This is acknowledgement. So the strong leadership by Professor Yamamura realized this Rituximab study. Then also, Dr. Okamoto is a neurologist who is a principal investigator of this trial. Thank you very much for your attention.
We have time for 1 or 2 questions. I have one advice regarding the primary endpoint. I would change the fatigue score that we used in the first trials. It's not so very good because of recall bias and because in that they should compare their clinical state as compared to baseline, but they forget after half a year or 1 year. So I think you should rather use SF36 or one or the other, but that is just an advice from us because we skipped that.
Thank you.
Any other questions? Carmen?
If we give advices, I would include only patients after infection triggered onset.
Thank you.
So thank you so much.